Drugs for diabetes. Before discussion on the classification of drugs for diabetes, I should mention that there are two main types of diabetes. Type 1 is called insulin-dependent diabetes. This means that patients are dependent on daily insulin injections because their own body, pancreas, is not capable to produce this vitally important hormone anymore. In type 1 diabetes, actually only insulin is relevant. All this classification goes to type 2 or insulin-independent diabetes. In patients with insulin-independent diabetes, key problem is increased insulin requirements because of inability of peripheral tissues to react to insulin properly. In the beginning of second type or insulin non-dependent diabetes, plasma levels of insulin usually are elevated. Then they decreased, became normal, and with exhaustion of capabilities to secrete this hormone, insulin levels became lower than normal. So, in type 2 diabetes, it is critical to tell that insulin does not dissolve problem. In type 2 diabetes, key problem is not insufficient amount of insulin. Key problem is resistance of peripheral tissues due to various reasons such as obesity. And therefore, initial step in the treatment must be dietary and dietary manipulations and exercise. Also, it is critically important to reduce body weight, despite this is really sometimes difficult. Next step in type 2 diabetes is administration of oral drugs, and first-line drugs are those which are proven to reduce the cardiovascular morbidity and mortality. Such drugs include metformin, so biguanide, as well as sodium glucose transporter 2 inhibitors. We can also classify the drugs for diabetes into injectable, those are insulin and glucagon-like peptide 1 analogs, and oral drugs, those are all remaining classes. There are actually 7 classes. Glucagon-like peptide 1 doesn't imply any similarity in pharmacodynamics. Rather, it implies just similarity in chemical structure. Then, we can also classify these drugs into those which increase insulin secretion, those are sulfonylureas and meglitinides, and those that increase insulin secretion and decrease its requirements. So he has two actions, and it is important to mention that sulfonylureas and meglitinides increase the insulin secretion independently on plasma glucose level. This means that even at low glycemia, they still stimulate insulin secretion. This is unphysiological mechanism of action. It may be dangerous, it is rarely addressed, difficult to adjust such a therapy. It should also be mentioned that key difference of sulfonylureas versus meglitinides is duration of action. So duration of action of sulfonylureas persists usually for 24 hours. Meglitinides, on the contrary, have shorter duration of action and usually have been used to control postprandial hyperglycemia. Meanwhile, GLP-1 analogs and dipeptidase 4 inhibitors also increase the insulin secretion, but this increase depends on plasma glucose level. So this is much more physiological action, much safer, and therefore these drugs can cause hypoglycemia much less commonly in comparison with sulfonylureas and meglitinides. Of course, most commonly hypoglycemia has been caused by insulin, which acts itself, and by sulfonylureas, which stimulate insulin secretion for 24 hours. Finally, we got 4 classes of oral medicinal products for diabetes which decrease insulin requirements, so they target the principal problem in type 2 diabetes, which is decrease in sensitivity of peripheral tissues to insulin. Insulin preparations mimic the pharmacological effects of endogenous insulin. So this means that there are no important differences in pharmacodynamics of various insulin preparations versus natural insulin. Insulin preparations differ in their pharmacodynamics, and therefore they have been classified to rapid and short-acting, intermediate and long-acting, and biphasic. Biphasic, it is not a distinct class, it is just a class which contains insulins, mixtures of rapid and short-acting insulins with intermediate and long-acting in order to avoid multiple injections. First, we start with insulin secretion, yet it is purely physiological slide what you see here. Now have a look on it. I removed some lines. Then you see that sulfonylureas and meglitinides have some effect on this physiological mechanism of insulin secretion. I will detail this later. Now you see some picture from Katsung showing how this insulin secretion works. So, if plasma glucose is high, then there is increase in transportation of glucose to hepatocyte by glucose transporter 2. Glucose is used is metabolized to produce energy, adenosine triphosphate, And adenosine triphosphate has been used to close potassium channel. Then, if potassium channel closes, then potential of the cell is normally negative, yes? So it increases until it reaches so-called threshold potential. At this potential, depolarization occurs, and depolarization opens voltage-gated calcium channels. So calcium enters from outside to inside, and it causes exocytosis or secretion of insulin. So this is physiological sequence. Why do I show physiology here? Because certain classes of drugs for the treatment of diabetes affect this physiological sequence. So you see already here that this is mechanism of action of sulfonylureas. It is not shown here, but it is also mechanism of action of meglitinides, another class. And actually you see that in this case, action of drug is largely different from action of glucose. So closure of channels does not depend on plasma glucose. So even in case of hypoglycemia, these drugs close channel and therefore increase insulin secretion and therefore even worsens hypoglycemia. So this is the reason why these drugs have hypoglycemia as very common. It means occurring in more than 10% of patients. So very common adverse reaction. And there are another drug classes, we'll discuss them later, that stimulate insulin secretion depending on the level of plasma glucose, and therefore they are responsible for hypoglycemia much less commonly. Then sources of insulin, it is not so important actually, because currently we have only on the market only human insulins produced by recombinant DNA technology. Pork insulin is seldom used, despite there is no clinical evidence that human insulin is better than pork insulin. I think pork insulin just was replaced by marketing reasons, without any clinical data of superiority. Just the data of non-inferiority. Human insulins are not worse. See, human insulins are produced by recombinant DNA technology. Pork insulin, it is just obtained from pork pancreas. And then, important note, modification of amino acid sequence have produced insulin with different pharmacokinetic properties. Pharmacodynamics stay the same. It is the same for all insulins. Meanwhile, pharmacokinetics is different. Mechanism of action. First, insulin binds to its receptor, transmembranous tyrosine kinase, to its extracellular domain. Then, the receptor, which also acts as enzyme, cause sequence of events in the cell. Here in cytoplasm we got insulin receptor substrate bound to tyrosine. And then this is activated, adenosine triphosphate loses phosphate, is converted to adenosine diphosphate, and here we got insulin receptor substrate already active. It is bound to tyrosine phosphate. And this active macromolecule activates two cellular pathways, which include phosphatidyl inositol 3 kinase pathway and mitogen activated kinase pathway. Next step is stimulation of the translocation of glucose transporter 4 to the cellular membranes. Here we got glucose transporter 4. It transports glucose into the cell, and this shows that this process has been activated by binding of insulin to its receptor. Then glucokinase stimulates the conversion of glucose to glucose 6-phosphate here. Although insulin stimulates glycogen synthase here and inhibits glycogen phosphorylates, therefore it facilitates glycogen formation. Finally, insulin stimulates glycolysis because it activates phosphofructokinase and also pyruvate dehydrogenase complex. So, for summary, insulin increases the translocation of transporters to cellular membranes, stimulates glycogen synthesis, and also stimulates glycogenolysis. So everything is directed to decrease the plasma level of glucose. Effects of insulin. Insulin acts on the metabolism of all nutritional substances, including proteins, carbohydrates, and lipids. Here we got intestine, various substrates following digestion activate insulin secretion in pancreas, as well as secretion of beta-cytotropic hormones by intestines. For example, glucagon-like peptide. Also, vagal stimulation is important for pancreatic function. Then insulin acts on the liver to stimulate the synthesis and accumulation of glycogen. Also, synthesis of glycogen and proteins occurs in muscles, and triglycerides accumulate in fat. All these processes are responsible to decrease in plasma glucose because it has been consumed for the synthesis of substances showed on this slide. Insulin is vital, life-saving therapy for patients with type 1 diabetes. They are insulin dependent. Also, insulin may be used in limited cases for the treatment of type 2 diabetes, but only in patients who fail to respond to dietary restrictions, increase in physical activity, and to oral hypoglycemic drugs. Also, insulin is critical life-saving therapy in case of diabetic ketoacidosis. Major route of administration include subcutaneous and intravenous. Subcutaneous is a usual route which is used for basal insulins. So basal insulins are those which cover basal insulin requirements to compensate inappropriate, insufficient basal pancreatic function. And also it is route of administration for postprandial insulins, which have been used to control postprandial hyperglycemia, so increase in glycemia after meals. Intravenous route is reserved to urgent conditions, so it is used for the treatment of diabetic ketoacidosis. Just note that only rapid and short-acting insulins are suitable for the intravenous administration and for urgent conditions.
Next slide is what is most important in pharmacokinetics. So you see some preparations of insulin with their peak and duration of action. You should remember the second line. So this is regular or soluble insulin, both peak and duration. And then you will be able to just compare another's. And note that in some textbooks, those times may be a little bit different, but just a little bit. So once again, regular or Lispro, it is considered short-acting, to be short-acting, and it has amino acid sequence same as insulin produced by human pancreas. Lispro is rapid-acting. And its name comes from change in the positions of two amino acids. So proline and lysine, they have different positions in Lispro if compared with regular or soluble insulin. And this, once again, has no impact on pharmacodynamics, but it produces some changes in pharmacokinetics with earlier peak and shorter duration of action. What is the reason for Lispro to appear on the market? Actually, it may be more comfortable to statin patients to administer insulin 5 minutes before meals, for example, than half an hour before meals. So, postprandial insulins have been administered actually before meals to manage postprandial glycemia. And timing should be made in such way that peak of glycemia coincide with peak of drug action. So to make sure that it is in this way, we should administer regular insulin half an hour before meals and Lispro 5 minutes before meals. Sometimes rapid-acting insulins may be administered even during meals or immediately after meals. So once again, both preparations above the line, Lispro and regular, are intended to control postprandial glycemia. Two preparations below the line are so-called basal insulins, and they are intended to compensate lacking basal insulin secretion. Neutral protamine hagedorn has protamine as excipient and the same chemical structure as regular insulin. So protamine makes absorption from subcutaneous injection sites slower, and this is responsible for different pharmacokinetics. So slow absorption makes pharmacokinetics different. So peak comes later and the duration is longer. Glargine also have slow absorption, but because of changed position of two amino acids, glycine and arginine. And the important note that those pharmacokinetic parameters are valid only for subcutaneous route. Adverse reactions. If one asks from what patient may die quicker, from diabetes or from treatment of diabetes? Definitely from treatment. Hypoglycemic coma may cause death in minutes, much more rapidly than ketoacidosis. So we need to remember signs and symptoms of hypoglycemia and to know how to manage this complication. To make it easier, we should understand that in case of hypoglycemia, body is capable to protect itself. So there are a lot of hormones that increase plasma glucose. They include glucagon, growth hormone, thyroxine, glucocorticoids, but also epinephrine. And action of epinephrine may be noticed. So if patient has hypoglycemia, then secretion of epinephrine increases, secretion of epinephrine in adrenal medulla, and patient has a lot of signs and symptoms of so-called adrenergic counter-regulation. So it is adrenergic because it is caused by epinephrine, and it is counter-regulation of decrease in plasma glucose. So in signs and symptoms of hypoglycemia, we see some of them are related to epinephrine. So tachycardia, sweating or diaphoresis, it's usually called, tremor or shakiness, blurred vision, and I would add Palpitation. Palpitation means that the patient feels how his or her heart beats. Normally, we do not feel this. In addition, hypoglycemia. Then there is hunger. Here you see increased appetite, it's more or less the same. Weakness or fatigue, also more or less explainable by hypoglycemia. Also anxiety may be related to epinephrine, despite epinephrine doesn't enter the central nervous system. What is the treatment? Treatment is easy. Some sweets, some juices, something what is sweet. Just note that everything is suitable, what is easily digestible and rapidly. However, sweets, what are intended for patients with diabetes, they are not suitable because they contain artificial sweeteners and they do not contain glucose. They do not rise glucose enough. If patient receives no help, then cerebral hypoglycemia develops. Then patient has confusion. Behavior becomes strange, but still treatment is the same. Treatment is the same as long as the patient has consciousness. If patient doesn't receive treatment, he may lose consciousness. And in patients without consciousness, treatment can be only parenteral. So treatment of choice is intravenous glucose. Patient regains consciousness in several minutes. And there is also glucagon, which may be administered intramuscularly. You see its mechanism of action and most important effect. So if it acts through catabolism of stored glycogen, so it will never be effective in patients who starved several days because there is no glycogen. And the only advantage of glucagon against glucose is possibility to administer intramuscularly, because not all patients have caregivers who are capable to inject intravenously. Intramuscularly, I think most of people can inject in the drug. And here, I think we need to note also that signs of hypoglycemia may be blunted or not appear in certain conditions. For example, if patient takes adrenergic blockers. Also, if hypoglycemia recurs after a short period, for example, if he has hypoglycemia yesterday, and also in patients with autonomic neuropathy. So in those cases, recognition of hypoglycemia is even more difficult. And finally, another adverse reactions. Weight gain, it is very undesirable because type 2 diabetes patients are usually obese, and obesity is a cardiovascular risk factor in addition to diabetes. Regarding lipodystrophy, You see, it is noted here, it is atrophy or hypertrophy of adipose tissue and the skin in the site of injections, but it occurs following frequent injection to the same site. So avoidances rotate site of injection, but within same part of the body. Why within same part of the body? Because absorption from different parts of the body may be different, it may have different rate, and then fluctuations of plasma glucose may be different. So if we inject into abdomen, then into abdomen. If into thigh, then into thigh, not interchangeably. Just site should be changed, but not area of the body.
Glucagon-like peptide 1 analogs include exenatide and liraglutide. The amino acid sequence partially overlap with human GLP-1. For liraglutide, the overlap is 97%. Glucagon-like peptide 1 analogs act as incretin mimetics. Incretin mimetics is a general name for gastrointestinal hormones which increase the action of insulin. These drugs bind and activate the GLP-1 receptor, which probably belongs to G-protein coupled receptors family. They increase the glucose-dependent insulin secretion and may also promote B-cell proliferation. They also reduce glucagon secretion after meals, so they lower inappropriately high glucagon secretion, and once again they act in this case also in glucose-dependent manner. Thus, when blood glucose is high, insulin secretion is stimulated and glucagon secretion is inhibited. Conversely, during hypoglycemia, liraglutide diminishes the insulin secretion and does not impair glucagon secretion. This is a highly important distinction from sulfonylureas and meglitinides, which increase insulin secretion independently from plasma glucose. The mechanism of blood glucose lowering by GLP-1 analogs also involves a minor delay in gastric emptying. Also, liraglutide reduces body weight and body fat mass through mechanisms involving reduced hunger and lowered energy intake. GLP-1 is a physiological regulator of appetite and food intake. Glucagon-like peptide 1 analogs have been used for the treatment of type 2 diabetes in patients who fail to respond to dietary restrictions and exercise. Usually, they have been used in combination with another medicinal products. However, sometimes they may be administered as monotherapy in patients in whom metformin is contraindicated or not tolerated. Liraglutide has been also used as an adjunct to a reduced calorie diet and increased physical activity for weight management in obese patients, or also in overweight adults with at least one weight-related comorbidity. In clinical trials with adult obese patients, liraglutide significantly reduced the rate of major adverse cardiovascular events. Yet, data on the effect on all-cause mortality is encouraging but limited. GLP-1 analogs, unlike the native GLP-1, have pharmacokinetic and pharmacodynamic properties in humans which are suitable for once daily administration. Originally, first product, exenatide, was administered before meals once daily. Currently, prolonged release exenatide is administered just once daily independently from meals, so its effect, which are dependent on plasma glucose, serve as basis for such administration. Adverse drug reactions are mainly extension of pharmacodynamic activity. They include nausea, vomiting, diarrhea, and they may also increase the risk of hypoglycemia related to sulfonylureas administered concomitantly. Oral hypoglycemic drugs include 7 classes. They may be subdivided to medicinal products which increase the insulin secretion. Those are sulfonylureas, meglitinides, and dipeptidyl peptidase 4 inhibitors. And another class is medicinal products which decrease the insulin requirements. Those are biguanides, thiazolidinediones or glitazones, alpha-glucosidase inhibitors, and sodium glucose transporter 2 inhibitors. It also should be mentioned that sulfonylureas and meglitinides increase insulin secretion independently on plasma glucose. Meanwhile, dipeptidyl peptidase 4 inhibitors, they increase the insulin secretion dependently on plasma glucose, and they also, in addition, reduce insulin requirements. Oral hypoglycemic drugs are indicated in type 2 diabetes if the patient fails to respond to dietary restrictions and exercise. Usually, first choice agent is metformin in patients who are not able to tolerate it or in whom it is contraindicated. Other medicinal products have been administered. Also, these medicinal products have been administered in combination with each other and other drugs.
First class, most important class, quite funny class, because this class contains only one drug, metformin. The drug has been used since the middle of 20th century, and mechanism of action is still not clear. You see here pharmacodynamics, but if you're trying to find some receptor, enzyme, or pump affected by these drugs, it's not possible. It's not known. So molecular target of action is not known, but probably main effect is inhibition of gluconeogenesis in the liver. Another possible effects appear in smaller fonts. Adverse reactions. You see that there are some adverse reactions very common. Actually, those are gastrointestinal disturbances. They usually appear in the beginning of the treatment. And this is the reason why metformin is usually initiated with lower dose, which is titrated later on. then the body may adjust and tolerate metformin better. And there is very rare adverse reaction, but may be fatal. It is lactate acidosis. Very rare means occurring in less than one patient from 10,000. Fortunately, this complication is may be avoided by considering contraindications and precautions. Usually, lactate acidosis was reported in patients with two kinds of diseases. Diseases that cause hypoxia or accumulation of metformin. So diseases related to hypoxia include severe cardiac and pulmonary diseases, especially acute ones. Also forms of another shock. And also renal failure, because metformin is eliminated through kidneys. So in patients with renal failure, accumulation of metformin occurs. And then this may also cause lactate acidosis. So hypoxia or renal failure. Metformin, it is still drug of choice in any patient who requires oral drug for the treatment of type 2 diabetes. So if there are no contraindication, then metformin is administered. You see what is major advantages. It reduces low density lipoproteins, very low density lipoproteins, and this reduction in their level is related to reduction in cardiovascular morbidity and mortality. Previously, this class was the only one capable to reduce cardiovascular morbidity and mortality. Currently, possibly we have one more class. I will say this later. If you have a look on adverse drug reactions, there is nothing said about weight gain. It is not increased. There is nothing said about hypoglycemia. So this drug does not increase the risk of hypoglycemia. It doesn't increase secretion of insulin. So it normalizes glucose rather than lowers it. And what it is also very important to tell, and which is quite strange for the first time, in patients administered metformin, level of insulin in plasma decreases. So requirements of insulin decrease and glucose decrease, and insulin, even lower level of insulin, is capable to control glucose better. Old, cheap, and best. It is not. It is really not often. This happens really not often. Next, sulfonylureas. I think you already know their mechanism of action, because this mechanism is closely related to physiological secretion of insulin. Just they block potassium channel without paying attention to plasma glucose. So it is not physiological block, which is related to important adverse reactions. I put here also duration of action because there is another class having a similar mechanism of action. We'll discuss it a little bit later. And this another class differs mainly from sulfonylureas in the duration of action. If you have a look on adverse drug reactions, so many of them are related to mechanism of action. Hypoglycemia, hyperinsulinemia, increase in body weight, all are related to this block of potassium channel and increase in insulin secretion. In addition, you need just remember rash and hypersensitivity. They are quite common. And I would say that despite appearance of very lot of drugs that for the treatment of diabetes, as many as 90% of drug consumption consists from insulins, metformin, and sulfonylureas. So we give most attention still to the same three classes. What students learned even 30 or 40 years ago. But also there are others. Meglitinides. You see, mechanism of action is more or less the same, just binding site on the same receptor is distinct from the site of binding of sulfonylureas. Main difference from sulfonylureas is shorter onset, faster onset, and shorter duration of action. Adverse reactions are also similar. Why they are less common? Sulfonylureas usually, effect of sulfonylureas usually persist whole the day. Meglitinides are mainly administered in conjunction with meals to control postprandial hyperglycemia, and therefore the effect does not persist all the day. So therefore, this is the reason for less common adverse reactions. Once again, hypoglycemia, once again, weight gain, but less common. Next. Next class had previously 3 drugs, but currently it has only 1, because first one, troglitazone, was removed from the market because it causes liver failure. Rosiglitazone is related to increased cardiovascular morbidity and mortality, so it is also off the market now. We have just thiazolidinediones, the only one thiazolidinedione, pioglitazone. You see that receptor is intracellular, so these drugs stimulate interaction of peroxisome proliferator activated receptors gamma with nuclear retinoid X receptors, and this increases expression of genes responsible for differentiation of adipose cells. So if differentiation of adipose cells is better, then they are capable to use glucose better for the synthesis of triglycerides. So this means increase in sensitivity to insulin, better utilization of insulin. These drugs usually are even not second, third option because of risk of very important serious adverse reactions such as heart failure and bone fractures, mainly heart failure. Next class, the only class which is not marketed in Lithuania, not authorized in Lithuania. So alpha-glucosidase inhibitors with very attractive mechanism of action. They inhibit enzyme alpha-glucosidase on intestinal brush border. Alpha-glucosidase is an enzyme required for splitting alpha-glucosidase bond. So it means for conversion of oligosaccharides and disaccharides to monosaccharides. And only monosaccharides may be absorbed. So if there is no absorption of carbohydrates, then glycemia should be controlled. And if carbohydrates stay in gastrointestinal tract, then they undergo fermentation in similar way as wine. So patient may have flatulence, winding, diarrhea, abdominal cramps, everything related to fermentation of carbohydrates in GI. Of course, they may be effective only if administered with meals, and only with meals rich in carbohydrates, because just in carbohydrates there is target of action. And not with monosaccharides, because there is no target of action in monosaccharides. So very attractive mechanism of action and very limited clinical efficacy. So therefore they are seldom used. But still. Next class. Dipeptidyl peptidase 4 inhibitors. So, dipeptidyl peptidase 4, it is an enzyme responsible for catabolism of incretins, hormones responsible for increase in effects of insulin. They, for example, decrease metabolism of GLP-1. So GLP-1 increases and it causes its effects. So finally, DPP-4 inhibitors have similar effects to those of GLP-1 analogs. Just DPP-4 inhibitors are not, have no nature, or they are not proteins, so therefore they may be administered orally. And adverse drug reactions, you see, most of them, most common adverse reactions are limited to gastrointestinal tract. If you remember, they both increase insulin secretion and decrease insulin requirements, but this increase in insulin secretion is dependent on plasma glucose. So risk of hypoglycemia is minimal. They just increase the risk of hypoglycemia related to another medicinal products.
Sodium glucose transporter 2 inhibitors, such as dapagliflozin, act on the cells of proximal convoluted tubules of kidneys. Here we got glucose and sodium in the lumen of tubule. Here we got a cell, and here transporter which inhibited by dapagliflozin and other medicinal products belonging to this class. In patients with diabetes, this reabsorption of glucose is harmful and contributes to glycemia because avid reabsorption of glucose continues despite of hyperglycemia. Sodium loss also contributes to regulation of circulatory blood volume and blood pressure. Loss of glucose also is responsible for the infections of genitals and urinary tract. It is important to note that cardiovascular benefit of this class was demonstrated. In addition to type 2 diabetes, sodium glucose transporter 2 inhibitors are indicated for the treatment of symptomatic chronic heart failure and chronic kidney disease. I note that those two indications are applicable also in patients who do not have diabetes. Adverse drug reactions include increase in the risk of hypoglycemia related to concomitantly administered medicinal products, genital and urinary tract infections, dysuria, polyuria, nocturia, volume depletion, and lactic acidosis. Note that both infections and adverse reactions related to increased urinary output are directly related to the mechanism of action. Antilipidemic agents.
Antilipidemic agents in cardiovascular risk reduction. First, we go to cardiovascular risk factors to make sure that we manage them before therapy. Things apart, and drug therapy is administered always in conjunction to the management of cardiovascular risk factors. So, first, 3 risk factors that may be managed both using drug therapy and lifestyle modifications. Next 4, those are mainly depending on ourselves. So, management of diet, lifestyle, smoking, and related obesity. Finally, there are congenital disorders, we cannot change them. Age is also important, but not included into this slide. Next, there are nomograms coming from British National Formulary and considering several, not all, cardiovascular risk factors. So, only people without diabetes are included here. You see consideration of gender, smoking status, age, systolic blood pressure, ratio of total cholesterol to high-density lipoprotein cholesterol, and blood pressure. Then, if we consider all those factors, we can estimate risk of cardiovascular disease over next 10 years. Green means less than 10%, orange 10 to 20, red more than 20, and even it could be much more than 20. And also, if you consider once again those risk factors, you may see that a part of administration of antilipidemic drugs, there is a lot to correct here, even without them, especially smoking and blood pressure, which should be treated with antihypertensive drugs. So, if we need to decide, should we administer antilipidemic drugs or not, always we need to estimate cardiovascular risk in patients in whom we would like to administer drug for the primary prevention, unless it has congenital or familiar hyperlipidemia. We'll discuss it later. Once again, slide on cardiovascular risk reduction. What can we do to change diet, get rid of smoking, to be active, and finally, if necessary, administer medicine. RRR stands for relative risk reduction. Relative risk reduction means reduction of risk in people in whom event would occur without an intervention. So let's say if we have theoretically 10 patients with myocardial infarction without intervention, so a relative risk reduction by 50% means that with intervention we have only 5 patients with myocardial infarction. And one more introductory slide is a slide on the metabolism of lipoproteins. Actually, it is not pharmacological, it is biochemical slide, but it is highly important for pharmacology because in this slide we can put targets of action of medicinal products, and even here we can explain most important what is most important in their mechanisms of action. So let's start from meals here. When we eat, we get some lipids, and there are nascent or growing chylomicrons in intestines. They have been absorbed into the blood and circulate as lipoproteins because lipids are not soluble in plasma. You see structure of chylomicron. They contain here cholesterol and its esters as nucleus, then triglycerides. Main component, also phospholipids and proteins here. Then, with the activity of enzyme lipoprotein lipase, chylomicrons lose their triglycerides, and finally we have only chylomicron remnants, which come back to the liver and then once again gain triglycerides and are converted to very low density lipoproteins. They are secreted as very low density lipoproteins. So what is the difference between chylomicrons and very low density lipoproteins? Actually, it's composition. Its composition, you see different size and different percentage of cholesterol, triglycerides, proteins, phospholipids in these lipoproteins. Very low density lipoproteins undergo similar pattern of metabolism in plasma. Once again, lipoprotein lipase metabolizes their triglycerides and convert very low density lipoproteins to intermediate density lipoproteins and finally to low density lipoproteins. You see here that low density lipoproteins contain high amounts of cholesterol. Low density lipoproteins have also apoprotein B100, which attaches to LDL receptors both in the liver and peripheral tissues. So after this attachment, LDL enter cells via endocytosis and has been used for the synthesis of cellular membranes, calcitriol, and steroid hormones. Note that there is no way of elimination of low density of cholesterol from peripheral tissues. The only only organ which is capable to eliminate cholesterol is liver. Hepatocytes are capable to eliminate cholesterol because they use it for the synthesis of bile acids. There are 7 classes of antilipidemic agents, but to tell true, 2 of classes contain only one agent. Ezetimibe and nicotinic acid are the only drugs in their classes. Also, one can say that statins are much more important, and sometimes we can classify antilipidemic agents to statins and others. Why I am telling this? It is because of the consumption of these drugs. Have a look on the consumption of antilipidemic agents in Lithuania from 2015 till 2019, and specifically in 2019. What numbers appear in this table? Actually, those are DDDs, defined daily doses. D. Defined daily dose is average daily dose for most important indication. And DDDs have been calculated per 1,000 of population. So DDD of 59 means that 59 inhabitants of 1,000 take average dose of some antilipidemic agent on daily basis. In other words, as many as 6% of Lithuanian population take antilipidemic agents daily. And if we have a look on different drug classes, you will see that consumption of another classes is negligible in comparison with HMG, CoA reductase inhibitors, or statins. And therefore, for this reason, we'll give most of attention for statins in today's lecture with just key facts about another classes of antilipidemic agents. What is the reason for this difference? Definitely, the reason is proven cardiovascular benefits of statin, benefits proven clinically. Regarding other classes, we can just estimate that they can be beneficial. Because if we know that increase in high density lipoproteins, decrease in low density lipoproteins, decrease in triglycerides may have a beneficial effect of cardiovascular morbidity and mortality, then we can assume that agents that have such effects on plasma lipoproteins may reduce cardiovascular morbidity and or mortality. Is it so? Regarding statins, it is proven. Regarding other classes, it is not proven. And this is the reason why statins are most important drugs. And also, in this lecture, we'll discuss size of this benefit of statins. Hydroxymethylglutaryl-CoA reductase inhibitors, or statins. All drugs belonging to this class have name which ends with statin. This is mechanism of action, of course, not everything, but what is most important. So most important, it is considered that it is most important effect of statins is effect on LDL, on low density lipoprotein. And let's have a look on the mechanism of this effect. Statins act as competitive inhibitors of the enzyme hydroxymethylglutaryl-CoA reductase, and this is a rate limiting step of cholesterol synthesis. So they reduce the synthesis of mevalonic acid, synthesis of cholesterol. If we have less cholesterol in the liver, then the hepatocytes adjust their function to get more cholesterol. So they increase the synthesis of mRNA for receptors of low density lipoproteins. So here in endoplasmic reticulum, on ribosomes, we have increase in the synthesis of LDL receptors. Then increased amount, increased number, increased density of LDL receptors on hepatocytes cause increase in clearance of LDL from blood. So liver uptake more LDL and more cholesterol. So this is the reason why LDL in plasma has been reduced. Another reason is that if cholesterol in hepatocytes decreases, then the synthesis and secretion of very low density lipoproteins also decreases, because cholesterol is necessary for the synthesis of very low density lipoproteins. Just you need to consider that the liver produces just very low density lipoproteins. It does not produce low density lipoproteins. Low density lipoproteins have been produced in plasma from very low density lipoproteins under influence of lipoprotein lipase. Next slide, effects of statins and pharmacokinetics. I would say that we need just a general idea of the slide. There is no necessity to memorize anything here. And if somebody asks, what is the clinical importance of different effects on plasma lipoprotein profiles of various statins? I would respond, nobody knows. Biochemically, it is clear, but in terms of cardiovascular morbidity and mortality, it is not proven. To show that one drug is superficial to another one in terms of cardiovascular and morbidity and mortality, we need direct head-to-head comparative clinical trials. There are no such clinical trials to compare one statin with another. So we cannot tell that atorvastatin or fluvastatin is better or worse than other statins. Maybe we can assume something in accordance to changes to plasma lipoprotein profile, but it is just assumption without any clinical evidence. And also we should note that for statins, other mechanisms may also be important, such as reduction in oxidative stress and vascular inflammation, because coronary heart disease events are reduced more rapidly than changes in morphology of arterial plaques occur. And specifically, we remember that statins reduce the synthesis of cholesterol, which is critically required for the synthesis of steroid hormones, of calcitriol, of cellular membranes. So they absolutely contraindicated during pregnancy and lactation because loss of statins, loss of cholesterol would lead to disturbances in formation of these substances in unborn child or in breastfeeded baby.
Medicinal products for gastric acid related disorders include proton pump inhibitors and histamine 2 receptor antagonists.
And first of all, we have basis, we have physiological regulation of secretion of gastric acid. There are several physiological substances involved in this regulation, such as acetylcholine, histamine, prostaglandin E2, gastrin. Then, histamine acts on G protein coupled receptors. We remember them from pharmacodynamics. And the type of this receptor is S. It means G protein receptor associative stimulation of adenylyl cyclase. This is a plus here. Stimulation of adenylyl cyclase causes adenylyl cyclase, then stimulated, it causes conversion of adenosine triphosphate to cyclic adenosine monophosphate, which later activates protein kinase. Protein kinase activates proton pump. Proton pump pumps hydrogen to the gastric lumen in exchange to potassium, but we are not interested in potassium in this case. And then mechanism of action of omeprazole. It just blocks this pump, directly blocks pump, so latest state of gastric acid secretion. This is a slide from pharmacodynamics. Once again, in detail, what I have already explained. Omeprazole is prodrug, enteric coated. It means that the coating dissolves just in intestines. So tablets of omeprazole may be also called gastro-resistant tablets. So in intestines, omeprazole has been absorbed. There is distribution, and then it goes to parietal cells of the stomach, where it has been activated. It means converted to the active drug, because it was just prodrug. It's also very specific properties, because usually prodrugs have been converted to the active form in the liver. So this is not the case for omeprazole. And he forms covalent bond with this hydrogen potassium pump. Somewhere here it makes a covalent bond. So it inactivates this pump forever. There is no gastric acid secretion by this pump until new pump is resynthesized. The pump which is blocked may not recover. However, synthesis of new pump requires about 18 hours. So duration of action is a little bit more than 1 day. A little bit less than 1 day. Therapeutic uses, actually those are diseases, conditions related to increased secretion of gastric acid. GERD, it is gastroesophageal reflux disease. So in patients with this condition, there is a reflux of gastric acid back to esophagus, up to esophagus. Then esophagus is not resistant to acidic environment, and therefore esophagus is damaged. Patient may have pain in the chest because of this reason. And then also erosions, so-called erosive esophagitis of inflammation of esophagus may appear. Then omeprazole has been used for the treatment of gastric and duodenal peptic ulcers. So ulcers caused by gastric acid. Normally both stomach and duodenum are resistant to the environment, but in various conditions, ulcers may appear, and before you see some specific conditions. So there are some class of drugs, so-called non-steroidal anti-inflammatory drugs, that commonly cause ulcers. If we go back to mechanism of action, in the same picture, you may see mechanism how non-steroidal anti-inflammatory drugs cause peptic ulcers. Those drugs block synthesis of prostaglandins. Actually, you have here already today that acetylsalicylic acid acts as inhibitor of synthesis of prostaglandins. Acetylsalicylic acid also belongs to this class. And here you see that prostaglandin E2 acts on G protein coupled receptors on the stomach. Just this G protein is associated with inhibition, the letter I, and its stimulation inhibits the same adenylyl cyclase, which is stimulated by GS protein. So if we block prostaglandins, we have increase in secretion of gastric acid. And once again, in some patients, this may cause gastric ulcer. And then there is some bacteria, so-called Helicobacter pylori, which has been found is as many as 95% of patients with ulcers. So definitely, this is one of the most important causes of ulcer, and eradication of these bacteria causes healing of ulcer. So there are different combination regimens to eradicate this bacteria, and those combination includes inhibitors of gastric acid secretion, such as omeprazole and antibacterials. And there are adverse reactions. In general, proton pump inhibitors are safe, but sometimes patient may have fractures or Clostridium difficile colitis. Clostridium difficile colitis is also associated with pharmacological effect if gastric pH is higher, less acidic. So then normal microflora may be changed in the intestines, and then this may provide better conditions to overgrow for this bacteria. Clostridium difficile colitis is really dangerous because it may be even fatal. This bacteria may cause severe damage of intestinal wall. And finally, we have H2 antagonists. They have been largely replaced by proton pump inhibitors, but still in use. Mechanism of action is very similar. They block the same sequence, just in different sites. So they act on histamine receptors to block them. Afterwards, everything is the same. Just consider that in this case, binding is reversible. And there are possibilities to stimulate proton pump by using other mechanisms, such as by gastrin, G receptors, or acetylcholine, M receptors. So it is not full block, it is effect is less. And in this example, you see cimetidine. It was the first H2 receptor blocker in medicine, but now it has been largely replaced by another, such as ranitidine, because cimetidine has much more adverse reactions. This is once again an explanation of the same mechanism of action. We have covered it already. Therapeutic uses are similar to omeprazole, just they are less because of less efficacy. And this is a slide to compare proton pump inhibitors versus H2 antagonists. As I told, proton pump inhibitors are more effective because of more potent secretion of gastric acid. There are a lot of cases that proton pump inhibitors are preferred over H2 antagonists, and there are some cases that proton pump inhibitors should be used and H2 antagonists are not suitable. So this case is ulcers associated with non-steroidal anti-inflammatory drugs.